Introductions. So, Dr. Aritra is clinical nutritionist and critical care nutritionist and diabetes.
We can start. Because people know me very well. Okay, because all are very known to me. Anyway, because of obese people doesn't mean that he or she is with the proper nutrition. He is also malnutrition, because undernutrition and the overnutrition in a second bracket both are malnutrition. So malnutrition is the major problem, but the data says is 2019-2020 5.5% of Indians living with the obesity, and the NHP's data says the obesity 20.6%, 24% are rapidly increasing. So major contributors of the obesity. There are a lot of factors, not only the lifestyle but also genetic predisposition. There are a lot of genes, because we all know about the genes called the thripty gene, like Kipte gene in Bengali, but the major contributor for the obesity. And not only that, the dietary intake, the environmental factors, genetic factors, heredity, the races, everything depends on the obesity. And not only that, there are a lot of medication, because we are seeing on the patients in the clinic, in the hospital, that we can see after having the psychological drugs, which are actually the SSRI or SNRI, selective serotonin reuptake inhibitors, that also causes obesity. Because nowadays depression is not only a kind of a thing that we can discuss is about. Depression is a disease. Depression is a disease. There are a lot of psychological problems are going on. That is also under a disease. So that comes. Dr. Reddy's and Nestlé Health Science for inviting me, and I'm seeing so all the persons who knows me and we know each other. Okay, so there is no need introduction. We are coming back to the topic of today, that is the GLP-1 era and the guidelines of GLP-1 era, and what is the GLP-1 era and the diet nuances. That is very important thing. Then because after the GLP-1 RA, that people thought that there is no role of a dietitian. What would be the role of a dietitian? Because GLP-1 era and GLP-1 injections will be helpful for the patients for doing their weight loss, sustainable weight loss and everything. Then what is the point for keeping a clinical dietitian for that? Which is absolutely wrong. Because after the GLP-1 era, from the day zero, the clinical dietitian's role to be a very much pragmatic and very empirical, and they should do a holistic approaches management for the cornerstone of patients is on the GLP-1 RA. So what is the GLP-1 era and GLP-1 RA, that I will come on later on. So basically we will talk about the obesity. So what is the obesity is all about, we all know. Because obesity nowadays in our country is a haywire thing. Because after the obesity there are so many of comorbidities, so many of different diseases can come up for the obesity. Not only that, after the obesity, the new term has been come up, there is sarcopenic obesity. Maybe if people are obese, there are a lot of the abdominal fat, lot of the visceral fat, but the muscle percentage are very less. This is called the sarcopenic obesity, the sarcopenia. The sarcopenia, obesity, sarcopenic obesity, these all together are very much synergistically approach that we need to take care, and from the day zero, mitigating all these problems. So this is the approachable that we will do, where the data says that globally 13% of the obese people, which is adult, and 39% are overweight. Because we all know about our ICMR BMI calculation, where we can talk about the 18.5 to 23. The people are basically with the normal BMI, more than 25 are overweight, and more than 30 is the obesity. Obesity grade 1, grade 2 and the grade 3 and the morbid obesity. But this is not only the cutoff. Apart from the BMI, nowadays so many other tools that we have to maintain of their muscle percentage. Maybe with the DEXA, maybe with the InBody, maybe with the hand breath meter, dynamometer, everything that we can see a muscle. So there are a lot of hospital dietitians are there, Vijay is there. There are a lot of tools for the malnutrition screening in the muscle we can see. The malnutrition screening means there are the mass tool, maybe there are the subjective global assessment, maybe for the critical care Nutric score. Lot of different scores are there where we can actually think about their muscle, because the main thing, we are the clinical dietitians, what we can do the diet counseling. What we can do? We can do a proper calorific diet prescription. Previous days, the ancient days, the diet charts were different. Maybe people are calculating 1200, 1400, 1600, 1800, so and so on. But nowadays, things has been changed. Nowadays, where we are talking about the precision medicine, we do talk about the precision nutrition. Where the nutrition, there are a lot of things are altogether determined. Maybe with the genetics, maybe with the chromosomes, maybe with the DNA, nutrigenomics, everything. Maybe two persons are sitting together, one person have the 2% have the same disease, but we are giving one person is 1200, one person is 1400. But depend on the lot of things and lot of factors before prescribing or calculating or formulating a diet prescription. That is very important. So, these are the major comorbidities linked with the obesity. Major comorbidities linked with the obesity means hypertension. We all know for the obesity, hypertension can come up, liver problem can come up. Previously, the liver disease, we used to say about the NAFLD, non-alcoholic fatty liver disease. Really, nowadays what we can say, do you have any idea? NAFLD or MSH. That is metabolic associated fatty liver disease. Because in all about the fat distribution in your liver, all about the basically the steatosis. The fat is all about. But previous days we didn't talk about too much of the metabolic problem. But nowadays we talk about the metabolic problem like obesity, metabolic problem like diabetes, metabolic problem like overweight. All together we can completely switch over the term to NASH to MASH. Non-alcoholic steatohepatitis to metabolic associated steatohepatitis. This is predominantly very important, and the paradigm shift has been changed because in the ancient days or previous days with the hepatic encephalopathy patients or HE patient, we try to do the protein restriction. We are not giving too much of the protein. Why? Because that time people think that if you give too much of the protein, what will happen? Lot of ammonia can secrete, and lot of ammonia to your small intestine stored, so your ammonia level will be higher. But after that we can see if you restrict the protein, what will happen? Catabolism will happen, because nitrogen, the catabolism things will happen. So much of the catabolism again increases the ammonia. So now the new medical consensus or medical data has been changed, and they can say you have to give ESPEN guideline. GLP-1, what the function GLP-1? Basically the GLP-1 function to increase your insulin secretion. Increase your insulin secretion and decrease your glucagon production. Decrease your glucagon production and also reduce of your neoglucogenesis and the other pathways and also the liver things. So this is very important that you have to maintain with the GLP-1 your brain, your heart, your pancreas, your GI tract and your liver. So for the patient who are suffering from acute pancreatitis or chronic pancreatitis or problem with any kind of hepatic encephalopathy or decompensated or compensated liver disease, those patients are not suitable with the GLP-1 RA, because GLP-1 RA will predominantly work with your pancreas and the liver, and definitely GI tract, alimentary canal are the major factors where after having this drug, what will happen? Your brain cells, because we all know, leptin, ghrelin, we know. What is leptin basically? Any idea? Pallavi, any idea? Hunger hormone. Ghrelin is a hunger hormone. And what is leptin?
Satiety.
Regulates our satiety. So basically ghrelin is a hunger hormone, is secreted from our stomach, and leptin secretes from our adipose tissue, adipose cell. Simultaneously adiponectin also secretes from our adipose tissue. But the thing is that sometimes leptin resistance is worse, so that's why we are having so many of foods. You can eat food. Not for this discussion, you can enjoy your food. So this is actually, but adiponectin is not working. but adiponectin actually working as a metabolic regulator. পাখা যদি বাড়ি আমরা কি করি, রেগুলেটর দিয়ে কমিয়ে দিত। তো দিস adiponectin acting as a metabolic regulator. যদি আমার খুব বুড়ি হয়ে যায়, if we have too much of the visceral fat, too much of the adiposity, this adiponectin can't work. Adiponectin shut down. তো adiponectin যদি শাট ডাউন হয়ে যায় তো রেগুলেটর কাজ করবে না, তো পাখা পাঁচেই চলবে, খুব জোরে হাওয়া হবে, ঠান্ডা লাগলেও কমাতে পারবো না। Why? Because adiponectin is not working properly. Leptin resistance is there. So too much of the ghrelin. Too much of the ghrelin means hunger hormone. There are lot of appetites are there. Appetites means আমরা জানি চোখের খিদে। What is চোখের খিদে basically?
Cephalic appetite.
Cephalic appetite. Cephalic appetite, gastrointestinal appetite, hedonic appetite, pleasure eating. আমার এটা খেয়ে আনন্দ হচ্ছে, I am having this food, আমি আনন্দ পাচ্ছি, আমি খাচ্ছি। কি হচ্ছে না হচ্ছে আমি জানি না, I am giving the too much of pleasure. Okay, and cephalic appetite means চোখের খিদে। রোলের দোকানের পাশ দিয়ে যাচ্ছি, I had my lunch. ও কি ভালো রোল। When I was a university student and a particular shop, I am not taking the advertisement, বলেই আমি থেমে গিয়ে রোল খেতাম ওখান থেকে, এত ভালো রোল। This is called the cephalic appetite. But we always try to work with our gastrointestinal appetite. What already they have said, why? Because this is actually maintain our chrononutrition, circadian rhythm, and proper gastric motility. We have our gut microbiota, altered gut microbiome. This is altogether working with our gut liver axis, gut brain axis. So this is predominantly in our hand. How do we work in such kind of a things? Okay, basically what did we say? We say about after having any particular of the food, what we'll try to do. Food, their proper mechanism, their digestion, their glycolysis, Krebs cycle, and the electron transport system chain. Electron transport system chain, or the ETS cycle. So how the way we have to utilize our food. We try to always utilize our food to ADP to ATP, adenosine diphosphate to adenosine triphosphate. আমরা ছোটবেলায় পড়েছি NADP to NADPH, আমরা শক্তি উৎপাদন করব। We try to maintain our energy, but sometimes what will happen? Sometimes fructose also will be our enemy. Why? Because sometimes fructose, they will enter with your de novo lipogenesis or de novo synthesis pathway, but this kind of fructose will acetyl-CoA, malonyl-CoA, succinyl-CoA, and also mono, di, and the triglycerides. A simple lipid. So triglyceride formation will be much more higher. And this, যদি আমাদের মাইটোকন্ড্রিয়া কোষের রান্নাঘর হয়, তাহলে শক্তিটা মাইটোকন্ড্রিয়া করছে। সবাই লাইফ সায়েন্সে আমরা পড়েছি, তাহলে মাইটোকন্ড্রিয়া sometimes disturb. They have too much of the oxidative stress and they have too much of the problem with the reactive oxygen species. চিকেনে কোনো অসুবিধা নেই, এগে কোনো অসুবিধা নেই, পনিরে কোনো অসুবিধা নেই, but if we do too much of the deep fry with the oil, what will it do? That will increase the reactive oxygen species, increase the free radical, and that can increase the reactive oxygen species, inviting lot of non-communicable disease like diabetes, cardiovascular problem, obesity, and all together. So how the way we have to choose our food. That's why nowadays choosing is food is important, but cooking mechanism is simultaneously important. A dietitian doesn't mean she will help you for cooking in a hospital kitchen and everything. Maybe the therapeutic part would be there, with the food management will be there, instructing to the pantry boys. But the thing is that they will instruct what kind of oil would be best for you, what kind of mufa, pufa, maybe a low trans fatty acid will be helpful for you. They will guide, because dietitians are the food doctors. They will help you to mitigate all this kind of a metabolic problem, and they will do it synergistically. So these things will have to understand the physiology, a biochemistry, and a part of the food chemistry also. This will help you to mitigating all those things. Maybe I have lactose intolerance. I have gluten intolerance, I have a problem with the galactose, then what food will be allowed for you? Nowadays, you can see the FSSAI guideline, they have mentioned about the food labeling. So, samne je pata thake, lot of there are advertisement, lot of marketing gimmicks, but the main funda in the back side. You can see what amount of the sugar, what amount of the sodium, what amount of the the permitted color, permitted additives are there. You can read. This is the way you have to educate and counsel to your patient that whatever you have to purchase from the shop, shop or any kind of shopping mall, try to read. I am there to help you out. At least discuss with me. Before purchasing, discuss with me. That is the helpful for them. Otherwise, so many things are available in the market. So not everyone is good for your health. That could be a big patience. So mitigating all those things, we have to always try to understand what our patients are doing. Okay? So this is very important part. So step 1, after and practices, patient-centric advice and the troubleshoot on the follow-up. Follow-up is very, very important. You do know one particular, maybe I am not going too much of the set point theory and the fat cell can come up with the obesity and the mood disorder. Mood disorder like depression, lot of depressive attitude, lot of neurological problem can come up with the obesity because there are lot of PubMed index journal says if you are obese, if you are android obesity, so your visceral fat acts as your endocrine organ. So basically they are all working as an endocrine organ and they are having of too much of the pro-inflammatory cytokines. So increasing of the pro-inflammatory cytokines, that is tumor necrosis factor alpha or interleukin 6, interleukin 8, IL-6, IL-8, that can increase the risk of the obesity. Not only that, the risk of the mitochondrial dysfunction and also the oxidative stress can come up and leads to the lot of comorbidities like type 2 diabetes, metabolic factors, hypertension, liver disease all together. And simultaneously, these pro-inflammatory cytokines that actually reduce your muscle mass. If your muscle mass is reduced, then sarcopenia will come up. Maybe you are obese, then sarcopenic obesity will happen if you are having this kind of problem. Okay? So, weight loss drivers of the health benefits, where we can see these things can come up gradually, type 2 diabetes, dyslipidemia, hypertension, NAFLD to MASH, PCOS to PMOS, and also depression, which is a very, very, very household problem nowadays like diabetes, like depression. Moner অসুখ হয়েছে, ও কিছু না moner অসুখ, nothing ও কিছু না. You should consult with a neuropsychiatrist or a psychiatrist or a psychological counselor for depression, because depression again considered as a major disorders nowadays. It's not like ও কিছু না moner অসুখ হয়েছে ঠিক হয়ে যাবে. If someone has a problem with your knees, পড়ে গেছে, হাঁটু ভেঙে গেছে, আমরা বলি কি আপনি হেঁটে চলুন, কোনো অসুবিধা কিছু নেই. আমরা কি বলি go for orthopedic surgeon, কারণ মনের কষ্ট হচ্ছে না, উঠে পড় ঠিক হয়ে গেছে, ও চল. No, it's not চল. You have to consult with a consultant for your neuro problem, because your neuro problem can invite lot of other comorbidities. That is very important thing. So the cutoffs, already I have said the BMI cutoff, underweight, normal, overweight and the obese, and the blood test, which is a very, very important, the blood parameter that we have to say. Debunking of the blood reports for the clinical dietitians are very, 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 very important. Because these kind of particularly maybe the WBC, maybe the total count, maybe the high sensitive CRP, C-reactive protein, maybe the ESR, if the elevated, then something is happened, untoward is happened in your body. You have to talk with the clinician, followed by a clinical dietitian for discussing all those, mitigating all these problems. So the blood report, reading of a blood report for a clinical dietitians is very, 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 very important. So you have to see the blood report, you have to consult, maybe you can do line up or map up with the clinician or physicians and walking. So this is all about the synergistically, a holistic, a multidisciplinary management. Not a single doctor will help you. doctor, clinical dietitian, psychologist, psychological counselor, all those things mitigating all this problem are very, 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 very important. So these things are so many important that we have to take. So what is the current guidelines for the obesity management? Now the bariatric surgery, pharmacotherapy and the lifestyle modifications. Now I'm coming to these things also. So what is the bariatric surgery all about? You know the bariatric surgery, a lot of surgeries nowadays are happening. That's mini gastric bypass surgery, Roux-en-Y operation, gastric bypass. There are surgeons, bariatric surgeon or gastrosurgeons are doing these things also. Again the cutoff. The cutoff is if it is BMI is 35 with any kind of comorbidities like type 2 diabetes and all those things, then you are eligible for the bariatric surgery. Data says. The data says, the clinical data says, if you are the problem of the BMI is the more than 30, then it will again, you are going for this any kind of drugs. Previously, Allistat was there. Allistat, what is the problem of Allistat? After having the Allistat, oily stool, rightly said by Mashallah, oily stool like steatorrhea. Steatorrhea can come up with your stool and lot of vitamin deficiency can occur. So the Allistat nowadays are not that much of important. Nowadays, what are they important? Predominantly, well, Dr. Gaurab will say much more about the drug, that is GLP-1RA, glucagon-like peptide, what? Receptor agonist. It's not antagonist, it's an agonist. This is a receptor agonist. Basically, these drugs we all know very well, semaglutide, tirzepatide, liraglutide. But semaglutide is only GLP-1RA, but the tirzepatide, I'm not taking the drug's name over here, and tirzepatide, GLP-1 and GIP. Now, what is the GLP role? Because Dr. Reddy will say sometimes about the GLP plus, we have the GLP plus. Now, what is GLP? GLP ki khai na mathay dai. So, GLP actually glucagon-like peptide. We have. Human bodies have the GLP. This GLP can't store in our body. Because GLP predominantly we can found the enteroendocrine L cells from our distal small intestine and the gut. Basically, this is the habitat of the GLP, and this GLP will not take too much of time in your body. It destroys. Why it destroys? Because this is an incretin hormone. Why it destroys? It destroys because the help of the DPP4, dipeptyl peptidase 4, DPP4. I think there are a few physicians are there. Who are the physicians? Can you raise your hand? Who are the physicians? MBBS? MBBS students or MBBS? You are, right. Okay, fine. So, those people will deal with the DPP4 inhibitors. So, what is the DPP4 inhibitors basically? DPP4 inhibitors are the drugs. They are sitagliptin, linagliptin, vildagliptin. So, these inhibitors actually, they are prescribing for mitigating the diabetes management and the obesity management. Why? Because we have the GLP-1 in our body. So, the DPP4 destroys. They will not help to stay in your body. Because these are your own, your bioactive, your physiological, biological DPP4. That's why for the diabetes management, DPP4 inhibitors are prescribing for the patient suffering from type 2 diabetes. So many other things are there. I'm not talking of the time. And why? That's why this synthetic synthetic GLP-1RA been invented. How is it invented? This is a synthetic. They are taking from the yeast Saccharomyces cerevisiae for making these peptides. So this is something different. It stays. It stays. Why it stays? Because this is a injectable substances. After having these injectable substances, this is actually walking your gut-brain axis. They are going to your hypothalamus. They are activating of your hypothalamus, activating of your leptin. They are basically stopping the ghrelin. That's why your appetite regulator. Your appetite regulator. So, যখন পেশেন্টরা আসবে, আমি জানি না কজন এখানে GLP-1RA patient দেখেন, দেখবেন patient the day they are taking the injection, they are saying কি আজকে আমার খিদে লাগছে না, Because anorexia can happen, and this particular kind of a injection, they're actually walking of your brain, your central nervous system, with the vagus nerve and the central nervous system, they are activating of your brain nauseatic center. So after having this kind of a injection, your nausea, vomiting will be much more occur because the nauseatic center is being activated. The nauseatic center is being activated from your hindbrain. They are basically nucleus tractus solitaries. Nucleus tractus solitaries are growing up and they are actually forgiving. Ki amar ajke khide nei. So ami jodi boli after having the GLP-1 RA ajkei eto protein khete hobe, it's merely impossible. It's merely impossible. Why? Because that particular day patient are having anorexia. This is the practical. I have seen more than 200 GLP-1 RA and GLP GIP. Why? Because tirzepatide have the GIP. GIP is the basically glucose dependent insulinotropic polypeptide or gastric inhibitory polypeptide that actually the benefits are working with the fat metabolism and the fat absorption and slowing down the ectopic fat in your body. So this is the basically the major phenomenon if you're getting the drug from the tirzepatide. But the semaglutide having this kind of phenomenon is not there because this is only the GLP-1. So that particular day patient is suffering from anorexia. Why? Because already I talked about your hindbrain, your hypothalamus mechanism, because your gastric emptying rate is much more higher. We do talk, being a clinical dietitian, about the chrononutrition. What is chrononutrition? Any idea? You very well you have explained about the chrononutrition in another seminar.
The timing of the plate is very important, not
Yes.
just the quantity. Timing is very
Yes, timing of the food. Basically, আমরা যদি মিউজিক শুনি, গান শুনি, and the proper peristalsis movement of a food, it will actually helps the food digestion, metabolism, absorption, mitigating all the disease. So that is actually very much subjective for managing all the disorders. So this is actually working with the so this is all about the pharmacotherapy. These things we have said. Now the lifestyle modifications can come up. So what is lifestyle modification? Like your diet. Your diet, maybe any particular given day you are prescribing 1200 calorie. A patient with the GLP-1, patient that not able to have that much of calorie. So we can starting with the pacing strategy. Pacing strategy means preferably you are giving 80 grams of protein, but not the 80 grams of protein, you are giving it a single dose. It could be early morning, to your breakfast, to your mid-morning, to your evening supper and your dinner. This is the pacing strategy of a protein. So you have to give 1.2 to 1.5 gram per ideal kg body weight. That is very important. Because I do talk about nowadays the hot news is that there soybean versus eggs. Eggs versus soybean. Why this is the hot news? Because there are vegetarian, non-vegetarian, all those things are why? Because maybe there is some different agenda not coming of that part. But again, the biological value are important. Because the biological value if 100% means your protein actually for your good for your digestion and the absorption. So the biological value, PDCAS, those who are MSc students, you all know very well the NDP cal percentage, net dietary protein calculation. আমরা MSc তে অ্যাডভান্স নিউট্রিশনে অঙ্ক করে দেখি যে কত কেমিক্যাল স্কোর, NDP cal percentage কত, তার biological value দিয়ে. I'm not going that much of theory over here, but that is very very important. So the protein কতটা খাচ্ছি that is not important. কতটা আমার ডাইজেশন হচ্ছে, অ্যাবজর্পশন হচ্ছে, that part is very very important. And here the picture where the nutraceuticals come up. In the Dr. Reddy's, there are lot of products are there. Recently they have launched with Celebita GLP+. These things actually you're mitigating the bridge the gap between your normal therapeutic conventional diet between your others diet which are actually getting from this kind of a nutraceuticals. I don't see the supplements because these are lot of empirical studies, lot of pragmatic studies are there. So these are actually bridge the gap between what you are missing. Key miss করছেন because after having the GLP-1 GLP-1 RA, what will happen? Not only on nausea, vomiting, anorexia, but also sarcopenia. Because sometimes this kind of injection, there are a lot of celebrities, Bombay celebrities, I'm not taking the name, you know him or her very well, you can see their faces like a conkalshar chehara, skeleton faces. Why? Because muscle has been destroyed. So we have to increase the muscle mass. Muscle mass is very, very important. Sometimes this kind of injection, what they will do, they will kill your muscle, they will destroy your muscle, and they will destroy your muscle inside your fat. So this is a very much important for predominantly we have to discuss about your muscle. So our objective to store the muscle mass, our objective to reduce our fat mass and store the muscle mass. So that's why we need a proper dietary counseling, and that should be calorie calculated, that should be individualized, and that should be customized to a person to person. Not like a printed diet chart to giving here and there. যে আসছে ডায়াবেটিস তাকে 1200 ক্যালোরি 1400 ক্যালোরি লাইক আলু পটল কেনা বেচা হচ্ছে. This is not like that. I think Vijayadi will agree with me and other seniors will agree with me. That is very, 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 very much important. Because nowadays diet prescription should be case specific and the precision based medical practices. This is 2 to 1.5 gram per ideal kg body weight. So protein importance is very, very, very much important. Nowadays you can see there are a lot of tantrum is going on, egg versus soybean versus rajma, so many things also. So we talk about the protein. People are not thinking about the other nutrients and the biological value of the protein, critical score of the protein, but we do talk about the protein. That is very important. So liver disease is one of the major phenomenon. Reproductive disorders, this is also infertility. PCOS term has been changed. So what is the new terms of the PCOS? Anybody have an idea? PMOS. What is the full form of the PMOS? Polyendocrine metabolic
ovarian
syndrome or diseases. So the terminology has been changed. Again the term is M, metabolic. What Vinny said that metabolic like MASH, again the PCOD has been changed to PMOS. So this metabolic. So metabolic things is the key factor for discussing everything. Okay, that is one of the things because we can see oligomenorrhea, amenorrhea is happening for this kind of people who are adolescents or the adulthood, and infertility automatically will come up. So how to mitigate all this problem through the diet and come up. Heart diseases, very, very important part. If you have too much of the abdominal obesity, you can see your waist circumference is much more higher despite of men and women. They can suffer with maybe with the left ventricular ejection fraction is lower, HF rev, heart failure, maybe with the problem with this metabolic obesity with the atrial fibrillation, on cardiac issues, ischemia, or any kind of cardiac problem can come up. So also heart disease is one of the major factor having comorbidity linked with the obesity. Type 2 diabetes, we all know very well because lot of insulin problem, insulin resistance can do occur to type 2 diabetes, where nowadays we talk about the remission and the type 2 diabetes followed by people are suffering from the frank diabetes patients. Dyslipidemia, also the high cholesterol level, high triglyceride level has been come up. There is a very, very again the major phenomenon where these things can come up, and also the cancer. Cancer risk can come up with the prostate cancer, with many things. Resting metabolic rate, resting metabolic energy, and also what particular food, because we have our own hypothesis and also their food mechanisms are there. Because যদি আজকে রাত্রিরে আমরা বাড়িতে থাকতাম, we can have a one roti or two rotis with some vegetables. But now in the Regenta or course, we have a sumptuous dinner is waiting for us, followed by a good appetizers. So what will happen? Our own homeostasis mechanism in our body has been changed. So that is rectifying certain changes. Maybe that could be amplified in your body. So that is the mechanism that we have to see the plateau effect. That's why dietitian follow. Oh, একই diet দেবে, যাবো না ওর কাছে, ওনার কাছে যাবো না. So you can do the doctor shopping, another dietitian. No, you have to keep on faith your dietitian. Do the follow up when they will be asking for you. Okay, that is very very important. This is the way you have to educate your patient. And patient ভাববে কতদিনের diet, and you know very well quackery things are going on. So they are doing a 3 months package, 2 months package, 6 months package, something like of that. So this is not a package system. This should be a proper clinical practices by a clinical dietitian should be the key for mitigating all of the problems. So the goals for obesity: reducing body weight, 5 to 10% weight loss, maintenance interim goal, additional weight loss if desired. So this is the very very important thing that we can see. Now, what would be the challenges? The challenges would be we have to do a proper rational diet practices. There are a lot of diets in our market. Intermittent fasting, maybe alternate day fasting, time restricted feeding, keto diet, paleothelic diet, Atkins diet, GM diet, Ornish diet, so many diet, theoretical in your book, theoretical, lot of things are available in the market also. It will do these things, but this is the temporary. This is not for the lifelong process. This is the temporary process. The lifelong process only you have to do a proper mechanism of the proper distribution of your carbohydrate, your protein, your fat, your minerals, your vitamins, your fluid, and your antioxidants and other nutritional factors. That is very important. So your carbohydrate platter should be roti, maybe oats, maybe dalia, maybe chura, maybe so many of things. So the calculation, the carbohydrate portion size or carbohydrate calculation is very very important in your diet. That should be this mitigating all those things. So that is very important. Number 2 is your protein part. That is 10 to 10 should be is from the first class protein or the second class protein, and all together make a protein that should be good biological value, good critical score, and also there is the important the protein distribution. The pacing strategy should be there, the way you have to take in the protein. The fat distribution should be their percentage of the monounsaturated fatty acid, polyunsaturated fatty acid, and the saturated fatty acid. The mono should be 10 to 15% from any kind of oil available in the market. Poly should be less than 10%, and the saturated fat should be less than 7%. Try to restrict the trans fat. Lot of cookies, lot of fried foods, lot of fried chips, lot of samosa having too much of the trans fat. So সেগুলোকে আমাদেরকে কিন্তু একটুখানি বাদ দিতে হবে. And also the salt is very very important parameter. What about your sodium? That you should take with the salt from what kind of blood pressure medications you are taking. So if you are taking so many of blood pressure medication, your salt intake should be limited, and not the on top of the salt and on top of the outside any kind of preserve and the junk food, because they are preservative. There are lot of sodium is there. Lot of sodium means lot of water retention. Lot of water retention means lot of obesity, abdominal fat that can happen. So this is very important thing that, and also low calorie diet will be preferable. 800-1200 calorie would be there. What I have discussed with you that after having the GLP-1 RA, because I will be discussing what is GLP-1 RA is much more details. But the problem is that because they are actually occurring for their nucleus tractus solitaris, the hindbrain particular timing, and they will actually occurring the nausea, vomiting center, and loss of appetite can happen to the gastric emptying rate. So this patient, আমি বলবো আমি খেতে পারছি না. So if you are giving off too much of the calorie, the particular day they are not having of that much of of your plate. So maybe 1000, 1200, sometimes 1100 can be happen. So you have to maintain that much of calorie. But the research says If you give the calorie less than 800, what will happen? There are a lot of formations of the gallbladder stone, a high uric acid level, high triglyceride level can come up. Lot of free fatty acid synthesis can come up if you give too much of the very low calorie diet. So very low calorie diet is not be preferred. What are being lot of slimming centers can do this in very low calorie diet, but that is not be preferred from a clinical dietitian. The diet should be at least 1000 kilocalorie diet, not less than 900, not less than 800 kilocalories. So low calorie diet would be preferable, but very low calorie diet wouldn't be. And the exercises, you try to encourage to your patients that do some resistance training, at least 150 minutes of walking followed by resistance training. If you don't do your resistance training, your muscle build-up, muscle synthesis can't be walk. Because muscle synthesis only can walk. Maybe you are prescribing leucine, you are prescribing valine, you are prescribing isoleucine, you are prescribing beta-hydroxymethyl butyrate, lot of things. If you can't do your exercises, this will not happening properly. So the resistance training would be the beneficial factor that you have to do. Maybe the patient is a heart failure patient, the ejection fraction is less than 40%, 30%. Maybe cardiologists have said, according to the New York Heart Association's guideline, that the no exercises at all. They can do at least হাত পা নাড়াতে পারে বসে এইটুকুনি করতে পারে, but again that could be a heart failure patient is a different. But apart from the patient, they don't have any kind of cardio problem or cardiological problem, they can do the resistance exercises, training and all together. Unless and until you do not do any kind of exercises, your whatever the protein, whatever the GLP plus you are taking, like Celibita GLP plus you are taking, your protein will not work synergistically. So exercise would be the part of your diet that you have to do followed by your diet. Okay, that is very important thing. And also this is a very important pathway. I'm not going too much of details, but that is a very important pathway, the mTORC1 pathway. If you talk about the leucine, isoleucine, valine, where this kind of a leucine which is predominantly present in the beta-hydroxymethyl butyrate, the HMB, and the modern research says, lot of published in this journal says that 3 gram of calcium HMB is needed. That's why the percent of the leucine, isoleucine, valine 2:1:1. Always leucine would be the higher state, because this leucine is actually your mTORC1 pathway, mechanistic target of rapamycin, mTORC1 that is actually working of your GATA2, and this GATA2 and the mTORC1 pathway, actually your protein synthesis, your protein basically they will store the pathway is a very important ubiquitin pathway that actually killing the degradable protein, but this mTORC1 pathway and the GATA2 try to increase this kind of a protein and they can be stored protein. So this mTORC pathway with the followed by the GATA2 is a very important pathway for maintaining of your leucine and your HMB. So this HMB and the leucine, so branch chain amino acid predominantly, which are very important for your muscle generation, your muscle store, and reducing the muscle muscle loss activity. So sarcopenia will not happen if you do a resistance exercises followed by your diet, and also your this kind of a supplementation if you take on top of will be better. This is better for the liver patients as well as also, because what I discussed before, modern guideline says the protein, ESPN guideline predominantly, the protein will be 1.2 to 1.5 grams per ideal kg body weight, and that should be with the proper BCAA, branch chain amino acid. We try to restrict the aromatic amino acid, like try to restrict the tryptophan, phenylalanine, tyrosine. Why? Because this kind of a protein, your increase of your ammonia production, and also this contains sulfur, methionine, and cysteine containing amino acids. So you try to restrict, maintain the Fisher ratio, increase the branch chain amino acid is a much more higher, because BCA actually will help you for mitigating all the liver problem, you're managing your diabetes, your obesity, and also for your muscle synthesis. This is very important. Okay, so these are the guidelines So guidelines we have to follow properly. Already have discussed the RSSDI guideline. I'm not repeating these things also. I talked about the low calorie diet and very low calorie diet. We can follow the low calorie diet, but doesn't follow the diet below 800 kilocalorie. Again, it can increase of your gallbladder stone, increase of your triglyceride formation to the de novo synthesis, and increase of your problem like hyperuricemia, like your uric acid metabolisms will much more higher. So this is a thing that we have to, and this is a chart that we can maintain the very low calorie diet for the fatty liver disease. I'm not going this part. This is a meal replacement. Already I spoke so many times about the meal replacer. This is not the meal replacer, but this is actually bridge the gap of your normal therapeutic conventional dietary management on top of a nutraceutical, which can help you for mitigating all these disorders. And those nutraceuticals have the study and the good amount of the biological value and the Pitika score that is actually helpful for the people for managing. শুধুমাত্র সাপ্লিমেন্ট খাবে খাবার খাবে না, that is not true, and that is not true also the day the GLP-1 RA is injecting সেই দিনকেই আমি এত প্রোটিন খেতে দিলাম, patient will end up with the vomiting, diarrhea, lot of problem can come up. So efficacy of meal replacement with a compared to food-based diet I've already taken. So these are the drug. Already I've talked about the GLP-1, GIP, all this that because already Sir will tell about these things also. GLP-1 RA, I'm not going this drug details. You all know before I talked about the linagliptin, vildagliptin, which is actually the GLP-1 RA that doesn't have any kind of problem with the DPP-4. But normal GLP-1 in our body, that DPP-4, they will not help to store the GLP-1 in your body. It can destroy. But synthetic GLP-1 RA can't. So this is the long term for the obesity. Gastrointestinal issues can come up. Already I talked about this thing: hypoglycemia, kidney problem, pancreatitis, cardiovascular risk. There are a lot of things can come up. We can combat with this lot of problem with this also. This is a book. The author is sitting over here because this is a really important part. But I've tried to maintain that the visceral obesity. So visceral obesity actually they are increasing lot of pro-inflammatory cytokines like T1 necrosis factor alpha, that IL-6, IL-8 are actually inviting lot of cardiometabolic, obesity, diabetes and syndrome X problem because this can increase the oxidative stress, increase the free radical, reactive oxygen species. So mitochondria মানে ভীষণভাবে ক্লান্ত হয়ে পড়বে. They will not work properly because mitochondria the main function the ADP to ATP they will can't do with the ATS. So this will happen. So always you try to restrict the foods you are taking, not too much of the fried food, junk food, because lifestyle modifications is only in our hand. Neither genetic, neither mutation, neither any other factors. Clinical evidence of GLP-1 RA. So GLP-1 RA is basically if a patient is suffering, say there lot of gut microbiota problem will happen there, altered gut microbiome. So after having the GLP-1 RA, some patients are suffering from constipation. After having GLP-1 RA, some patients are suffering from diarrhea. If a patient is suffering from the diarrhea, then we will try to give the low FODMAP diet or the low residue diet. If maximum the patient suffering from the constipation because very slower gastric emptying rate, slower peristalsis. So this will actually taking too much of time for taking the water from the interlumen pressure for having a good stool. So constipation is a very phenomenal thing. So in that cases, the Fibersol, which is working the resistant maltodextrin, this resistant maltodextrin actually is good for the patient who are suffering from this constipation problem because this is not working in your small intestine, is working in your large intestine, large colonic epithelium, and this part actually what they will do, they will actually increases the short chain fatty acid SAFA, that is acetate, butyrate and propionate. This short chain fatty acid they were binding with the receptor of the free fatty acid receptor FFA2, FFA1 are they're working with the G coupling protein. So these kind of a protein actually mitigating all the problem and they are the dietary fiber actually try to keep the store of your own GLP in your body. So these glucagon-like peptide or the GIP and peptide YY, tyrosine, actually this dietary fiber will help you to store in your body. So if you are wanting these things from your diet, so good amount of the dietary fiber, soluble dietary fiber, insoluble dietary fiber, specific soluble dietary fiber, lentil carbohydrate, resistant maltodextrin plays a very good role for your own GLP in your body. I'm not talking about the GLP-1 under this thing. So this is all about the key takeaways. We have to follow a diet with a precision-based medical practice with the dietitian and calorie specific, and the diet should be much more of a person to person. It's not about a printed diet chart. Number two, after having the GLP-1 RA, what could be the diet nuances? We always do follow not the theory but the pragmatic approach. Try to listen from the patient, what they are suffering after having the injection. That is very important thing. Third thing, importance and role of the dietary fiber. And the fourth thing also, the multidisciplinary approach, and also the approach from a dietitian, a physician, diabetologist, all together. If you're working for a patient, then we can try to mitigate all those problems. This is the cornerstone for the diet management for reducing obesity, diabetes to some extent, and also nowadays GLP-1 RA being launched up, having given a tremendous good role for the patient. For the day one, a clinical dietitian's role would be very important. Thank you so much for your patient listening.